can we give a little bit of immunotherapy for our patients?
How is it that the breast surgeon and oncologists are taking different views in my case?
I think there's a question, is lumpectomy recommended for young patients in their 20s?
Welcome to this second episode of the Triple Negative series as we explore treatments for triple negative breast cancer. Watch previous episodes at Talk Health Asia's YouTube channel. Subscribe to stay updated.
Prof Yip, we're looking at you. Can you explain a little bit of the different surgery options there are for patients with TNBC?
Well, TNBC is treated like any other breast cancer. When it comes to surgery, we still decide whether to do lumpectomy or mastectomy. So lumpectomy is when we just take out the breast lump, and mastectomy is when we take out the whole breast. Whether you're triple negative or any other type, you can still do either this or this. Lumpectomy is based on the size of the tumor in relation to the size of the breast. I think there was a question asked to Kim why she's 4.5 cm, she managed to do a lumpectomy. It is possible because your surgeon must be very clever, because they probably did some oncoplastic work. You know, you can take tissue from elsewhere to cover the defect. So you can do a big lumpectomy and still get a fairly okay breast. But the most important thing is that there must be only one lump. If you are multifocal, that means you have a lump up here and a lump down here, then I'm sorry, you have to take out your whole breast. Also, when you do a lumpectomy, the margins must be clear. And in early breast cancer, if the lymph nodes are not involved or whatever, you must be agreeable to radiotherapy. I have some patients who do a lumpectomy. I said, you must have radiotherapy. They say, yes, yes, yes. And after you've done the lumpectomy, margins are clear. And then they turn around and say, why do I need radiotherapy? My margins are clear. And then you have to go again to explain, oh, you have to, you know. And also patients have to understand that even with radiotherapy, there's a 10% chance, because your breast is still there, that there's local recurrence. So you need to monitor the breast. But if local recurrence occurs and you detect it early, you do a mastectomy, you are still cured. So that's the difference between the two. Lumpectomy is associated with, in a way, better quality of life because the breast is still there, so maybe less depression. So even if you do, I think there's a question, is lumpectomy recommended for young patients in their 20s? Yes, if their tumor is small enough. Even if you need a mastectomy, you can do a reconstruction using the fat and muscle from the back to make a new breast, or the next one, you can use the tissue from the tummy to make a breast, and you get a tummy tuck at the same time, you know, but this one takes a bit longer. Or you can use implants, which is not so good because you have a foreign body in you forever, you know. There was a question to say that one woman said she had a mastectomy, she still needed radiotherapy, because if you have lymph nodes involved, even after a mastectomy, you would need radiotherapy to the chest wall. Okay, so these are the options of surgery. And you, if you have BRCA positive, the chance of contralateral breast cancer is almost 50%. Normal, in a normal woman without BRCA, the opposite breast cancer is only 5%. I have patients nowadays who wants to take out both breasts, even if they are not BRCA. And I tell them it's only 5%. Why do you want to take it out? And even the American Association of Breast Surgeons say that you should not actually be doing contralateral mastectomy for no reason. Because in a woman who doesn't have BRCA, the risk is only 5%. But of course, if you have BRCA, then it's okay to take out both breasts and do a bilateral reconstruction. And we have done this before. I mean, just for interest, I had one patient. I mean, I was looking at one patient. She had triple negative breast cancer, and she had neoadjuvant chemo first. And it's good because that neoadjuvant chemo period gave her time to consider BRCA testing. So she had time to do the BRCA testing because it takes like 3 weeks to get the results. If you want to do it before surgery, like you have upfront surgery, you have to wait 3 weeks for the result before deciding on whether to take out your breast or not. Come to think of it now, I actually have 2 patients waiting for the BRCA result before they decide what surgery to do. So usually it's too rushed, you know, like Nina said, they are coping with so many things, and yet they have to cope with the counseling and testing and all the issues, you know, related to having a mutation, Yeah, this woman. And she had time to think of it. And after that, she had after the neoadjuvant chemo, she had bilateral metastatic, reconstruction, and radiotherapy. So this is like what Nina says would be a good sequence, You have triple negative breast cancer, you have neoadjuvant, you do your BRCA testing, then you decide on your surgery type.
And you walked us through lumpectomy, mastectomy, and reconstruction. What about axilla surgery?
Oh, axillary surgery. You see, you can do nowadays, if clinically, I have to say this, if you have very early breast cancer, clinically your lymph nodes are clear, then you can do sentinel lymph node biopsy. But if clinically your nodes are involved, your mammogram, ultrasound, or PET-CT shows your nodes are involved, then you have to remove most of your nodes. Women always ask, they're going to remove 100% of my nodes. Usually we don't really remove 100%. Probably the most we can get maybe 75% of your nodes, If you remove 100%, then maybe the incidence of lymphedema will be higher. I think there was a question about arm swelling. The arm swelling you get, I did a study in years ago on this. It's 8% only after axillary dissection. It's only 8% the clinically obvious lymphedema, so it's not common, It's more common if the oncologists go and irradiate the axilla. But nowadays, Nina, I don't think you all give radiotherapy to the whole axilla, do you? It's very scary when we dissect the axilla and then get radiotherapy in it as well. Do we do that, Nina?
No, we don't do dedicated axillary radiotherapy. But I think what we're talking about is, after doing axillary surgery where you take all your lymph nodes out and then there's radiotherapy on top. So the added effect can increase your risk of lymphedema.
Prof, can you explain for the benefit of women here who have not experienced breast cancer, can you explain for their benefit, when you talk about lymph nodes, which sort of part of the chest is it just there, and what does a sentinel lymph node biopsy involve?
Well, sentinel lymph node biopsy is only for early breast cancer where clinically your nodes are negative, So we inject blue dye around the tumor and we take out the node that turns blue because this would be the node that first drains the breast. And if this sentinel node is negative, you assume the rest of the nodes are negative. Different women have different numbers of nodes. Some women, if you do an X-ray dissection, you get 40 nodes. Some women, you only get 10 nodes. So the number of nodes is variable. It's not as you have 10 fingers and 10 toes, Number of nodes differ in different women. But if your sentinel lymph node have breast cancer, previously you would say that you would have to take out more nodes because you don't want to leave positive nodes behind, basically, but this one will be a discussion with the surgeon, Like that's a question why they never had sentinel lymph node removed. Maybe because clinically your lymph nodes were involved. Then the surgeon will not do a sentinel lymph node biopsy because sentinel lymph node biopsy is also not 100% accurate. There's a 10% chance that the sentinel node is negative, but there's a node higher up here which could be positive. So it's actually very much dependent on your clinical judgment at the time of surgery.
I see. Speaking of surgery, I think there's one thing that we probably didn't cover yet, the clip insertion. When is a clip actually useful to be inserted?
Well, you see, this is only used in cases where you're giving neoadjuvant chemotherapy. Nowadays, the oncologists are so good, especially with triple negative breast cancer. They give chemo, they add on immunotherapy, and I get a lot of complete pathological response. The tumor just disappears. Sometimes it disappears, you can't even see it on mammogram or ultrasound, but the oncologists will insist that we have to take out some tissue because they have to prove complete pathological response. Nina will tell you if you don't get complete pathological response, then they treat some more, with chemotherapy, awful. So if we can prove complete pathological response, then your prognosis is very good. That means your chemo and whatever you gave got rid of all the cancer. So if you got rid of all the cancer in the breast, then any micrometastasis in your body will also be gotten rid of. So I've had cases where we forget to insert a clip and we can't find the tumor. Then we will have to agak say, oh, this was where the mass was, you know. So, but if you put a clip here, look at this clip. It's put under ultrasound guidance, is here. And you see this clip here, this is a hook wire. We cannot feel the tumor. I don't know where to cut. So this hook wire is inserted by the radiologist under ultrasound because the clip is usually can be seen on ultrasound. So after that, the patient goes for surgery. I follow the hook wire in and I take out this whole area. And this will be sent to the pathologist and they will decide whether or not you have a complete pathological response, which is a very important outcome. The oncologist will tell you that, you know. Isn't it, Nina? We always aim for PCR, complete pathological response.
I mean, Prof Yip, you should see when I do get a PCR in clinic, I think my team and I would, I mean, especially me, would be jumping and really sort of high-fiving each other. Just very pleased, because for us, it does mean, as you said, sort of association with increased life expectancy.
There will be a jubilant air all around, wouldn't it, Dr. Nina?
Yeah.
Yeah, and then if you don't get complete pathological response, then everybody is going to be so depressed, depressed. And then you have to tell the patient, I'm sorry, but you need more chemotherapy, you know.
I think this is a good juncture, Dr. Nina, to explain neoadjuvant chemotherapy that you were touching on a little bit earlier on.
Sure. I think definitely at the end of the day, there is no one size fit all. As I've said before, traditionally, most of the time, patients will have their surgery first, and then we'll discuss chemotherapy after the surgery. But now in the current era, we do note that if we give chemotherapy before the surgery, it gives us a lot of chance to see what's the response like, to understand the tumor biology better, to try and get this melting of the tumor, so that when the pathologists look under the microscope, once the surgeon's taken it out and they can't see any cancer, that's associated with increased life expectancy. So we want to try and achieve that. If we don't achieve that, it gives us an opportunity to discuss with our patients the possibility of giving more chemotherapy or more treatment. At the end of the day, it is a discussion. More is definitely not better, but it's a discussion, because at the end of the day, it's a trade-off in terms of your quality of life and sort of side effects of treatment. But neoadjuvant chemotherapy gives you all these chances. And so, but it is not to say that every patient with triple negative breast cancer should be prescribed neoadjuvant chemotherapy. So for patients who have very, very small tumor and with no spread to their lymph node, then there is a chance to do surgery first and then do chemotherapy after that.
Dr. Nina, we have a question. I think you've touched on it briefly, but perhaps this lady Yu-Ting would like you to elaborate. She asked, how do you actually prove a complete PCR, a pathological complete response? How do you actually, what's the definition?
Sure. So again, I think what I really, really want to touch here, that's really important, is that no one doctor is responsible for your care. We must remember that there are a lot of background players that are so important in your cancer journey. So most of the time, the faces that you see on the forefront are usually your breast cancer surgeon and your oncologist, but actually, or chemo nurses, your radiation oncologist, but actually you have your pathologist. And what that means is that after your breast cancer surgeon, like Prof Yip, takes or remove the breast cancer, then they're being put and sent to the lab, and then your pathologist will section that, sort of cut it up into pieces, and then have a look under the microscope. And what they're looking at is, where is the breast cancer? Because remember, we've taken some biopsy before, so they are trying to find that, and appearance similar to that. Sometimes if a clip is in there, then that helps them orientate it and find it. And if the tumor melts away, they can see the fibrosis or scar tissue around that. So that's the appearance that they will look at, which will then determine that it's pathological complete response. So it's a real important report coming from the pathologist. Another shout out is to the radiologist. They are also sort of back end, but doing really, really important work.
What if you don't actually have a complete response? Is it that an indication of a higher likelihood of recurrence, or is that not relevant to that?
So the short answer is it does mean that there is a slightly higher chance of recurrence, and therefore it gives us a chance to discuss how we can try and reduce that risk of recurrence with further therapy.
Right. And would there be any difference whether the patient is BRCA positive in terms of neoadjuvant?
By and large, the treatment of a patient with BRCA positive in terms of systemic treatment is pretty similar to patients who don't have BRCA. However, there is new medical advancement that shows that adjuvant PARP inhibitor tablet taken for 1 year can reduce the risk of breast cancer recurrence in patients with BRCA positive. So what is PARP inhibitor? So it's a tablet called olaparib. And what it does is it's a PARP inhibitor. PARP is an enzyme that's responsible for DNA repair. So if you inhibit that PARP enzyme, lots of DNA in the cancer cell cannot repair itself. And because they can't repair themselves, then they will die. And that's how the cancer cell gets killed. So that's how PARP inhibitors work.
Let's go to the sort of practical side of the patient journey, right? When you talk about neoadjuvant chemo, and Ivan has asked this question, when with chemo reducing the platelet count, is there something what sort of diet do we go into to increase that platelet count? Is there a firm answer to that?
Sure. Ivan is not alone in this question. I get a lot of questions like this in my clinic. I think as a society, we have firm health beliefs. And one of that is whatever we put into our body is responsible for whatever that happens in the body. So, for example, sugar. Sugar is the reason why I get cancer. And that's a big myth, okay? So in terms of optimizing platelet count, there is no single food or ingredient that does that for you. Yeah.
Right. And Kwek Eng asked this next question, which is kind of relevant. With people on chemotherapy, it's often said that you should increase your protein intake. And she's asking, what source of natural protein is actually best?
Whole foods are really the best that we want to go for. So reduce as much processed food and processed meat and go for whole foods and sort of high rich protein, lean meat, chicken, fish are really good. And what's good is if you're able to do the method of cooking clearly matters. So in terms of steaming and cooking it in healthier manner, vegetables, peas, legumes, they are high. Nuts, they are high in protein as well.
Right. And with this, we have a question from FW. I think FW is just trying to understand a little bit on this chemotherapy. How does an oncologist determine the dosage of chemotherapy drugs for each patient?
So it's very traditional in the sense that we measure your height and your body weight. And from there, we input a specific formula, and that's called a body surface area formula. And then we prescribe that based on the drug and body surface area. However, there are reasons and indications that you might have to dose reduce. For example, if you've had chemotherapy complication like fever and low white cell count or neutrophil count, then your oncologist might want to reduce your dose of chemotherapy. But if there are no indications, we try as much as we can to maintain dose density, meaning maintain that 100% dose.
Right. Now, I have a question for Prof Yip, because we're seeing this question repeatedly, right? Where patients are experiencing different opinions between the breast surgeon and the breast oncologist, not necessarily between the both of you, but for example, Lucia asked, my breast surgeon said chemo is not needed if I get a mastectomy, but my oncologist disagreed and said I should do 6 cycles of chemotherapy. How is it that the breast surgeon and oncologists are taking different views in my case? Prof, how would you respond to Lucia?
Yeah, you see, for me, I said that I will give the opinion on the surgery, the oncologist's opinion on the adjuvant therapy. I would never dare contradict the oncologist. If they say they need hormone therapy, they need hormone therapy. I think Nina will say this is why multidisciplinary teams discussion is important. But this can only happen in probably in the university setting, isn't it? Or in the government setting, because in the private setting, we all work as individuals. So there's very little multidisciplinary discussion going on, because usually I will ask the patient which oncologist do they want to go to, because it's the patient's choice. Some of them will say, I want a woman. Some of them will say, I want an oncologist in this hospital, I think, Nina, I think you will have no problem, because in the university, I know you have a multidisciplinary team. So it's already discussed before the patient comes to your clinic. So there will be no disagreement between the surgeon and the oncologist what to do. Isn't it, Nina?
I mean, I think disagreement happens.
but it's not in front of the patient, right?
But they happen behind closed doors. So they're called academic discussion. And then we try to come up with an agreed action plan. I think, even in the sort of private setting, if a conundrum as such happens, I would think the discussion would happen from a physician to a physician, because to have a patient in the middle being confused is really I feel sympathize and empathize for the patient. Yeah.
Because I see some of the questions also, like the surgeon says, I don't need chemotherapy. The oncologist say, I need chemotherapy. Who's right? Who's wrong? That one, there's no right or wrong answer, because when you are the borderline, then it's very hard to say. There's obvious reasons for giving chemo. If you look at our Malaysian clinical practice guidelines, there's a guideline on when to give chemo and when not to give chemo, isn't it? So if they follow the guidelines, there should be no disagreement.
Yeah. And I think this is another question that's repeatedly asked in our chat box in 101 and in here tonight as well. What makes a good oncologist, and how would I know so-and-so is a good oncologist? Sensitive question. Dr. Nina, do you have any guidelines for the patients here tonight?
From what I've seen, patients do come for second opinion. And, I don't think that is that is bad practice. I think that's actually okay, as long as you don't confuse yourself further. Because sometimes when you go for third, fourth, fifth opinion, and then you're in a position where you get a lot of conflicting messages. So I think if you are thinking about getting second opinion, sort of limit to maybe one extra opinion and then make your mind up. The other thing is, the other consideration, if I was a patient, was to think about communication and how I feel with my doctor. So am I able to open up? Can I discuss? Is my doctor respecting what's important to me, so that we can align our goals together? So I think it's a tricky question to go beyond that.
Well, let's go back to Dr. Nina. You mentioned that, with chemotherapy, you mentioned sometimes it is combined with immunotherapy. Can you explain immunotherapy, Dr. Nina?
This is a topic that is being asked quite a lot in my clinic, and also by other healthcare professionals. So, oh, can we give a little bit of immunotherapy for our patients? So, first of all, what is immunotherapy? It is exactly what it says, immune and therapy. It's your own immune system, which is really your soldiers in your body trying to detect and kill the cancer cells. So that's what this immune checkpoint inhibitors enable our body to kill the cancer cells. So, you know, what happens? So what happens is, so I put a picture in this slide of the security checkpoint, and that's probably at an airport. So everyone's probably have gone through this security checkpoint. And this is really an analogy of how you should think about your immune system. So those security personnel are T cell or your immune soldiers. And what they're trying to do is trying to detect tumor cells when they scan you through. And the cancer cells or tumor cells are clever in the way that they can go undetected, right? So what these immune checkpoint inhibitors do is they enable the security guards to actually see these cancer cells and detect these cancer cells, and then enable them to kill the cancer cells. So that's the role of the immune checkpoint inhibitor. So I think in the chat, in the participants' questions before, they asked why was immunotherapy not prescribed to me when I have triple negative breast cancer. So there's a few indications and reasons for that. So number one is this is a fairly new drug that's on the market for this indication. And that, so for example, pembrolizumab is being given in the neoadjuvant or pre-surgery in triple negative breast cancer if you have a tumor that's large or more than 2 centimeters and node positive. So we also must remember that immunotherapy or pembrolizumab are not sort of given just a one-off. They're being given once every 3 weeks together with your chemotherapy. And then after your chemotherapy, you still continue with the immunotherapy afterwards. So in essence, immune checkpoint inhibitors or immunotherapy helps together with chemotherapy to further reduce the chance of breast cancer recurrence in triple negative breast cancer. So perhaps for patients who were diagnosed like 5 years ago, that was not standard of care treatment, but now it has become standard of care treatment. That's what we call sort of medical advancement, and it's moving at a very fast pace.
Right. And as good as it all sounds, are there any issues? I mean, given that it's such a new treatment.
Sure. So I treat my patients in University Malaya. So most of my patients are either sort of pensioners and do not have medical insurance. So these drugs, because they're new, are very expensive. And we do talk about financial toxicity being one of the side effects of being diagnosed with cancer. So these drugs are expensive, and they cost up to 17 to 20,000 ringgit for every cycle. One cycle is 3 weeks. And as I said before, it's a long treatment. So it's not a treatment that you want to just have for 1 or 2 cycles and feel that you have benefited from it. So it's a treatment that you want to have for at least a year. So for a year, 6 months or a year, in the early breast cancer, and for metastatic or stage 4 cancer, then you want to have it until the disease progress.
I'm just taking the calculator out because 17,000.
You could buy a house.
That's right. I'm just seeing many digits on my calculator right now.
Yeah, I mean, that is seriously, the study that has come out from University of Malaya saying that patients face financial catastrophe after their cancer diagnosis. This is a real issue. I mean, the other issues with regards to immunotherapy is side effects. So we talked just now about our immune system and soldiers in our body sort of turning themselves against cancer cells, so being more effective, but they can also turn themselves against our normal cell, and that can cause sort of inflammation. This is rare, which I have to say that this is rare. It doesn't happen frequently, but when that happens, patients can get inflammation of the lungs, so they can get breathless, inflammation of the bowel, they can get diarrhea. So these are all sort of fairly serious side effects, but by and large, for most patients, when they're going through immunotherapy, they do not get sort of similar side effects as chemotherapy. They feel that this treatment, when they don't have sort of significant rare side effects, is pretty easy to handle and better in terms of quality of life.
Does immunotherapy actually affect the heart?
So as I said, in the rare occasion, if your immune soldiers turn themselves against any organ, so if that organ is the heart, then yes, you can get inflammation of your heart muscle.
Let's talk about survivorship. Can we actually prevent relapse of triple negative?
I think the short answer is, I tell my patients the simple truth. Patients with early breast cancer come to see me, and I say, hey, actually the most important therapy is taking it out, is surgery. So because sometimes patient feels, if we've done the chemotherapy, can we skip the surgery? So actually we have to come back to the main core. The core is that surgery is the main curative treatment for your breast cancer. And oncologists act as accessory, and we try and give other treatments to try and reduce those risk of breast cancer as much as we can. But our therapies have got side effects, and as an oncologist, our aim is to try and balance those side effects and tailor that treatment for you. What can you do for yourself? I think this is the question that a lot of our participants and a lot of patients ask. Hey, so what about me? How can I empower my cancer journey? What can I do for myself? What can I eat? What can I do? So I think healthy, well-balanced diet. So we've spoken about that. And I think it's sort of making small changes. So not sort of radical change, sort of thinking about a well-balanced, healthy diet, more greens, more veg, more fruits, and making that slow increment or slow changes. And we talk about getting fit. So when we talk about getting fit, and a lot of patients, when I say the word exercise, they sort of completely switch off because maybe it's not part of their lifestyle. But I think what I want to try and pivot is to say moving. Just keep on moving, however much you can, and completely listen to your body. Why? Why is this important? The reason why it's important is if you are a fit individual, then if the cancer relapse, then you would be in a state that's fit enough to take as much aggressive treatment as possible. Not only that, you can adhere to your treatment better. And we know that it has lots of benefits in terms of your well-being. You sleep better, you reduce depression and fatigue.
I have one last question for the doctors before we wrap this panel discussion. What sort of surveillance should TNBC survivors do, triple negative survivors? Is it just the same as a normal breast cancer patient, or is it more sort of aggressive monitoring that should be done?
I think it should be the same, For me, I mean, as a breast surgeon, I actually do the follow-up together with the oncologist. There was a question like, who does the follow-up? I think both should do the follow-up. We always divide our work. For me, I look at the breast for any recurrence in the opposite breast. So I always do an opposite breast mammogram, or if they have lumpectomy, I do the mammogram ultrasound for them every year. So I see them once a year. Oncologists, depends on who, a lot of them will do blood tests once a year. And they might do a chest x-ray, ultrasound, abdomen, pelvis. Certainly, they don't do a PET-CT scan every year. I think there's a bit too much radiation. But the minimum is just a chest x-ray or ultrasound abdomen and pelvis. When I was in the university, and if you look at guidelines for follow-up, they don't recommend any scanning unless the patient has symptoms. Isn't that so, Nina?
Yeah, that's absolutely true. I mean, I think even in the sort of, if you're looking at guidelines in NHS UK, that clearly would be what is indicated. We don't do specific scanning apart from sort of mammogram, ultrasound every year, mammogram for the breast. But I think I want to touch upon something there in terms of being body aware. That's very different than being neurotic about every single symptoms that's coming through. So to be body aware, you need to understand and listen to your body. And if there is something that's out of sync, to listen closer and to think, is it something that dissipates or go away, or is it becoming increasingly obvious? And those are the reasons why you would want to see your whoever you do your follow-up with, a breast and we have joint follow-up between the breast cancer surgeon as well as the oncologist. But I think there are questions coming through in terms of after 5 years, I rarely see my surgeon or my oncologist. It's only once a year. This gives an important opportunity to remind ourselves to have a close link with family doctors. They are there for a reason. They're there for your worries, right? So they're really actually sort of the gatekeepers. And I find having a good relationship with your family doctors is important so that you can chat through things. Hey, doc, I have this and this. Do you think it's something more? So at least there's another layer before you go to your oncologist and to get it checked out. Yeah.
Yep. In terms of treatment, would the modality be hugely different for early TNBC versus late TNBC?
I once had a patient with a 8 millimeter screen detected triple negative breast cancer.
We are not talking about sort of aggressive curative intent, and what we are trying to do is trying to control the cancer.
Subscribe to Talk Health Asia's YouTube channel for more health chats episodes, or find easy to understand health videos on talkhealthasia.com.